Hi, everyone. This is Rupali Sharma from Wellington, New Zealand here. I would like to thank the Academy, particularly Sarah, for enabling me to make this presentation from such a distance. To be honest, I hadn't thought that this would be possible. It is summer here in New Zealand, and Wellington is looking fabulous on a bright, sunny day like this. I had a fantastic experience at the Parkinson's Academy MasterClass, Advanced MasterClass in June. I felt very stimulated in that environment of fantastic coaching and knowledge sharing. I returned home with lots of ideas. I was keen to do a project, the outcome of which could have an impact in changing the practice in our organization or could lead to some service improvement. And then we had a meeting on memorandum of understanding amongst various people involved in the service of or care of Parkinson's disease patients. One of the discussion point was the need for review of the Parkinson's medicine management in our inpatients. So, and we know that medication management is so crucial for Parkinson's patient, both in terms of timing and in dosing. So I decided to look at that issue and do an audit. So here's the topic of title of my project, which is an audit, and I've named it Inpatient Management of Parkinson's Disease Medication in a Tertiary Hospital. Just to give you a background of our hospital structure, Wellington Regional Hospital and Kenepuru Hospital are the two main hospitals under Capital Coast District Health Board, which covers a population of about 300,000 spread across Porirua, Kapiti, and Wellington. Kenepuru Hospital provides care for the geriatric inpatients who get admitted via Wellington Hospital, and occasionally there are direct admissions from the community. Majority of our Parkinson's patients are known to the neurologists and the geriatricians who run the multidisciplinary clinic every 2 months at 3 different centers, Wellington, Kenepuru, and Kapiti. We have been running this multidisciplinary clinic over the last 5 years. Now, as a groundwork for the audit, I looked for any previous work done at Wellington Hospital, but was not able to locate any. So I communicated through our WhatsApp group that we created during our last advanced masterclass. And Neil Archibald provided me some information and also advised me to contact Jane Alty from Leeds Teaching Hospital. I contacted Jane and she provided me details of some of her work, which was very helpful. I looked at the past projects on Parkinson's medicine done by the Academy graduates, which gave me ideas to plan the project. Then I discussed my project plan with our research officer from the hospital and devised a spreadsheet with details of what data to collect. My supervisor, Kate Scott, offered me great help in planning the audit. I aim to keep my study questions simple. First, I wanted to find out if there is any delay or omission of Parkinson's disease medication doses while they are in the hospital as inpatient. Next, if there was any significant delay or omission, whether there was any untoward consequence in terms of complication of the disease or any impact on the length of stay. In addition, I tried to look at other questions, which I'll explain later. It took me 3 weeks to get approval from the clinical audit committee, and as without their approval, I couldn't have access to the medical notes. I wanted to review the medical notes or admission notes for Parkinson's patients admitted for 6 months period between February and July this year. Medical coding helped me to identify patients using the ICD codes, and I hand searched the notes once they were available from the records department. Here is the list of the data collected. As you can see on the screen, I need to mention here particularly that regarding the delay in administration, I arbitrarily chose a time delay up to 2 hours as acceptable. It was difficult to ascertain the accuracy between the time recorded on the drug chart by the nursing staff and the actual time of intake of the medication, by the patients. Again, impact on the length of stay was difficult to assess. I looked closely at any comments from physiotherapists, medical and nursing staff about the Parkinson's disease symptoms and decision on discharge planning to see if there were any comments that would have led to the increased length of stay or any impact on the Parkinson's symptom because of any error. So coming to the results, a total of 80 case notes were identified. Of them, I had to exclude 29 cases, and I included 51 case notes. Of the 29 cases that I'd excluded, they had no formal diagnosis of Parkinson's, and they were not on any medications for Parkinson's disease. Of the Parkinson's medicines missed, there were 6 cases. Of them, in 2 cases, one patient was nil by mouth because of aspiration pneumonia, and he missed doses for 2 days. One was a surgical candidate waiting for the theater and missed the dose for 1 day. On the other 2 cases, the 2 patients were delirious and they refused medication for 1 day. And the other 2 cases, drugs were not available in the emergency department or in the ward. And that again they missed 2 doses. Amongst the delayed doses, the 2 patients missed their evening doses, 2 doses in the evening on 2 different patients. Regarding the complication, again, it was quite difficult to assess the complication because there are no clear documentation in the notes. And I assume that length of stay was probably increased due to missed dose in one of the case who had aspiration pneumonia. There was no prescription error. Medication list was available in all the cases. And patients were seen by a neurologist or a geriatrician experienced in Parkinson's in 75% of the cases. Moving on to the other results, the age of the patients ranged from 39 to 95 years, and majority were male. There were more males. Majority were from their own home. 33 out of 51 had documentation that they brought their own medicine to the hospital, but there could be or could have been more. Majority of the patients were admitted under general medicine, but patients were admitted quite across the hospital, which included neurology, orthopedics, geriatrics, and some surgical departments. Regarding the PD medicine, the most common medicines were Medopar and Sinemet. A few were also on amantadine, pramipexole, ropinirole. 1 patient was on salicylic, and 2 were on apomorphine. 55% were in their complex phase of the illness. Length of stay ranged from 0 days, and those were for the ED observation unit admission. And 1 patient stayed for a length of 34 days, where the patient had fall, fracture, and had delirium. The average length of stay was 8.7 days. The reason for admission were quite varied, and it included confusion, fall and fracture, stroke, initiation of apomine infusion on 2 cases, urine infection, pneumonia, tremor and anxiety, COPD, congestive cardiac failure. And a majority of them included in these broad categories. So I acknowledge that this is a small study and is a snapshot of admission over 6 months. There was no major incidence of medication discrepancy either in terms of timing or dose, and there was no discernible untoward consequence apart from 1 case of aspiration pneumonia where there could have an impact on the length of stay. Majority had medicine reconciliation, which is a service initiated over the last few years where medicines are reviewed by a pharmacist for general medicine admissions. I tried to look at the possible explanation. I found that the use of shared care, the link that connects the resource of GP's practice with hospital system, improved the accuracy in prescribing at the time of admission by the admitting doctor. The patients brought their own medicine on a number of cases, and that improved or reduced their delay in medication, because quite a few cases I've seen there's documentation of patients self-administering or the relative or carer administering while the patient was waiting in the ED. Now, over the past 4 years, we have a geriatric liaison service at the front door, particularly in ED and MAPU unit, and that service has improved. That improved the specialist review for those patients admitted through ED and MAPU. In some cases, admitting doctor has mentioned time-specific medicine in the drug chart that seemed to have increased awareness among the nursing staff in dispensing medicine. Now, this study could have easily missed incidences of delay, because again, I wasn't very sure of the accuracy of timings that was documented by the nursing staff and the exact time of intake of the medicine. Again, I was not able to judge some secondary effects from delay or missing the doses. There were no clear documentation of any stiffness or fall or declining, say, physiotherapy due to being more rigid, or similar comments that could have given me some information about the complication or effect of missing the dose. Again, some cases could have been missed that occurred outside the study period, which is between February and July. So looking back, I think, again, that my assumption of drug delay up to 2 hours as acceptable wasn't appropriate. We cannot assume and expect that patient would bring their own medicine every time they come to the hospital. So there is a need for a system where essential and common Parkinson's drugs are available in the emergency department or the ward across the hospital. So where to from here? This is the first step of the quality improvement cycle. I intend to present the findings to the wider audience, to my general medicine colleague, geriatrician colleagues, neurologist, surgeon, and to medical directorate. I want to look at implementing changes that could involve raising the awareness among both medical and nursing staff across all services, particularly those in ED and MAPU. I would look at the service that emergency department keeps a stock of commonly used Parkinson's medicines to prevent any delay. And again, I'll continue to encourage the clear documentation of phrases like time-specific medicine or give medicine on time in the drug charts. Again, I like to encourage the practice of patients bringing their own medicines when they present to hospital. It'll be quite important again to re-audit in the future to see if the awareness campaign has made any effect and has there been any improvement in the Parkinson's medicine management. Here are the sources that I have referred to, and I want to acknowledge and extend my thanks to the members of the Academy, the tutors, and my supervisor. And thank you from Wellington. Come and visit us here in Wellington. Thank you.